Dr. Maumer Durrani. I'm a consultant physician and a rheumatologist here at University Hospitals of Leicester. I do lead the research team for rheumatology as well, and do run specialized clinics in muscle disease, connective tissue diseases, and early inflammatory arthritis. I do also run a clinic of a diagnostic ultrasound in MSK. So we're going to go through about 20 questions regarding pharmacology and toxicology, which is a quite important subject in MRCP, especially part 1. And hopefully at the end of this presentation or class, you'll be able to have some basic knowledge of the important subjects for the examination and the question writers. So when we go through this, I will try to give you some common themes of the questions as well to concentrate more. So we might end up about coming out of this to know 3 or 4 or 5 types of scenarios where you need to have a further study and going through into the details. That will probably cover majority of your questions regarding the toxicology. So going to the first question. Now, which of the following circumstances would the treatment of anemia with the EPO, which is erythropoietin, still be effective or expected to be effective? Number A, infection; B, aluminium toxicity; C is folate deficiency; D is hyperkalemia; E is iron deficiency. So in this question, you have to think about what is the action of erythropoietin and how does that work. It's a stimulant, isn't it, in a way? And you need to have enough raw material like iron and all of those things to be able to work for this stimulant to improve anemia. So if we go to the answers, answer is D, which is your hyperkalemia. And explanation for that would be that erythropoietin, usually used in anemia of chronic disease related to chronic renal failure, it does a period of anemia in platinum-based chemotherapy, especially heavy metals, when they're used in, say, a breast or a colon. Secondary anemia related to your bone marrow suppression is helped by erythropoietin. Also, if there is anemia in premature babies with a low birth weight, this stimulates your bone marrow to make more red cells. In some situations, if there is an aluminium toxicity, which is a heavy metal, slightly different than the chemo we normally use, folate deficiency, because there won't be enough substrate, so folate is important in maturation of your red cells, and or any significant illness. In that scenario, even if you give erythropoietin, it might not be as effective. Ferritin is acute phase reactant. If your ferritin is low, then again your erythropoietin might not be that effective. In hyperkalemia, it does not directly affect any problems in terms of the bone marrow or any substrates like iron or folate or B12. So using erythropoietin in those circumstances ideally should work, and effectiveness is not affected. So just to give you guys a bit of a background, so going through these questions, it's not just what is true. You're going to learn a lot from what is not true, and there will be some explanation about that as well. So in a way, in one question, you will have some understanding of at least 4 or 5 principles regarding that. So if you go to the next question, another thing I just wanted to say that I was given time of 1:30 according to UK, but I think the IT team didn't realize that we do have this daylight saving time change, which is usually in the summer you go up and down an hour. So actual time was actually 2:30 rather than 1:30. So it may be that we are a bit short on time, but I'll try to cover everything and answer all your questions. Now, the second one is a young girl, 22-year-old, has acne and is taking oral medication. She develops polyarthritis and and raised liver enzyme tests. So if you look at the blood tests there, results AST is 98, upper normal range is 31, ALT is raised as well, bilirubin is normal, and she has strongly positive ANA, 1 is to 1600. So different labs give you a different type of reading. Some give 140, 1 is to 40, some which might be significant in that lab scenario. It depends on which type of blood test you're using, whether you're using ELISA or any different method. So according to our trust, the ELISA we use, 1 is to 1600, is quite significant. That means you take somebody's serum and put it on those large nucleated cells, usually liver cells, used to be, and cancer cells. So if you have antibodies, they're going to get attached to those cells, and you can see it under the microscope. Now, if you wash it, say 100 times, and you don't see antibodies, that means the concentration is 1 is to 100. But after washing it 1600 times, it's automated system, you still see antibodies. That means that it's significant. It's a larger quantity. So that's how usually we quantify ANA. A bit of ANA is not uncommon. About 10% of the normal population can have mildly positive ANA. So on its own, it's not a very diagnostic test. Right, so answers: A, oxytetracycline; B, trimethoprim; C, minocycline; D, isotretinoin; and erythromycin. So all of these could be used, most other than the antibiotics, most of these could be used for acne, but the correct answer is C here. All of the other medications on the list above, including minocycline, can be used for acne, but trimethoprim is an antibiotic for more urinary tract infections, so we don't use that commonly. Now, raised ALT, AST could well be related to hepatotoxicity of the drug. Now, the point here is that they have mentioned ANA, positive ANA, and a polyarthritis. So you have to just dissect down the question. Liver toxicity could be many drugs. Whichever drug you pick, it can cause liver problems on a wider range, starting from antibiotics to even paracetamol. You can go to immunosuppressives. You can go to, say, proton pump inhibitors. All of those can cause hepatotoxicity. But the thing which is different here is a polyarthritis and a positive ANA. So what you think about, you'll think about drug-induced lupus. So drug-induced lupus is a very interesting and a common topic for MRCP question writers. And I know that because I'm part of that. We do go through the questions and write those, and often with the question you see where you see a little bit of a rheumatology flavor, it might be me. So in drug-induced lupus, you have positive ANA. Sometimes antihistone is positive, but not every time. Most of the time, though. Lower incidence of nephritis. More common is your arthritis, usually, and positive ANA. Very uncommon to see a double-stranded DNA positive, and rest of the immunology is usually negative. Previously, the medications involved included that minocycline. We don't commonly use those anymore, but with the newer drugs like anti-TNFs we use for our autoimmune conditions, can cause that as well. So as a protocol in UK, you might just want to need to know that as well. We do ANIs for every patient. In fact, nowadays, double-stranded DNAs as well, who's going on an anti-TNF to make sure we know the baseline. So in future, if they develop any features and then a positive ANA, we know at least whether it's a new occurrence or it was already there. A lower renal involvement, not a lot of cutaneous involvement is either, but we do see some rashes with that. Procainamide, hydralazine, and the other drugs which are linked. And again, minocycline can sometimes is a bit unusual in a way that it can have immunological memory, whether it's saying it does form memory cells which come back with a vengeance if there is a second dose given. So sort of a stronger reaction with a continuous use. So a bit further regarding your drug-induced lupus. So as I said, ANA is positive. You can have increased gamma globulinemia. ESR is usually raised. Usually with the systemic lupus erythematosus, you don't see a CRP rise, but in this scenario you can. It could well be not just arthralgia, as a full-blown arthritis with synovitis. So that does give you sometimes a raised CRP. And males and female ratio. So as you know that SLE, systemic lupus erythematosus, is more common in females, 1:9 ratio. But in this scenario, male and female is the same. For some reason, Caucasians are more affected by this compared to Afro-Caribbeans or Asians. But if you look at the systemic lupus erythematosus, it's the other way around. So Afro-Caribbeans and Asians can have a worse disease, and it's more common in that subgroup. It's usually in the older age group compared to systemic lupus erythematosus, which is more earlier age group. It can cause serositis as well, fever, as arthralgia, so hence it can explain your raised CRP levels. Right, so uncommon to have renal, hematological, and CNS involvement. Usually self-limiting. You stop the drug within 4 to 6 months, it can disappear unless the patient had a susceptibility of already an underlying CTD, which just comes out with that basically. All right. So moving to the third question. Yeah, third question. Which of the following, so this will cover, the questions will cover a wider range of subspecialty conditions: cardiology, rheumatology, toxicology, some A&E presentations, some acute medicine presentations, you have some renal presentations. So this will cover not just pharmacology, but also some conditions as well. Right, so which one of the following antiarrhythmic drug may be used in treatment of long QT syndrome? So it's a very interesting and important question for MRCP question writers. So you need to have a further read about long QT syndrome and the drugs causing it, and the drugs you can use safely in that scenario. So the answers here: A, propafenone; B, amidrone; C, flecainide; D, sotalol; E, atenolol. So as a principle, beta blockers. So beta blockers are the main treatment in the long QT syndrome, and mainly the selective ones. So metoprolol, atenolol are utilized, but main like propranolol, nadolol are less used nowadays. Sotalol is a dual agent. It is classified as a beta blocker, but it does affect D and I isomers as well, so it prolongs repolarization, which is again a class effect, so might not be an ideal treatment in this scenario. In this scenario, best course of action is maybe it depends on how high the risk is, having an ICD implanted to reduce the risk of VT, which is polymorphic ventricular tachycardia, or sometimes torsades de pointus. You have to avoid any medications which lengthens the QT interval, because then you end up having these arrhythmias. Right. Number 4, a 55-year-old lady presents at the cardiology emergency department with a history of central chest pain, sweating, and dyspnea.
Sir,
Go ahead.
sir, can you explain regarding sotalol once again?
Yeah, so sotalol has a dual mechanism of action, right? So it is a beta blocker. It blocks your blockage of the beta activity, but at the same time, let me just go back so I can just, yeah. So at the same time, it has a dual effect. So there are two isomers, I and D isomers, that again affect class 3 antiarrhythmic effect, means that it will prolong, by affecting these isomers, it's going to prolong your repolarization phase, especially by the D. So that in that term, it can have your increased QT interval effect as well. So in this scenario, you might make things worse, because the dual action means although your beta blocker action is there, but then the other action will contradict that. So in that scenario, your sotalol might not be an ideal medication to give. Right, going to next question. A 55-year-old lady presents cardiology, crushing chest pain, sweating, and dyspnea. ECG confirms acute myocardial infarction. So you have ST elevations in leads V2 to V4 and ST depressions in lead 2 and 3. Now, which one of the following would be a contraindication to thrombolysis in this lady? Just to let you guys know, this question, although still comes in MRCP, is slightly outdated, because nowadays most UK centres have a primary PCI. So they just have, whenever they come in, they go straight to cath lab, have a angioplasty straight away, put stents in. So that's primary PCI, catheterization basically. But still, there are certain circumstances where we use thrombolysis. Right, so which one of the following would be a contraindication? A, intracranial neoplasm. B, history of peptic ulcer disease. C, pre-proliferative diabetic retinopathy. D, ischemic stroke 2 years previously, or having masturbation. Now you have to just...
Intracranial neoplasm.
Yes, intracranial neoplasm, yeah, malignancy. Contraindications to thrombolysis, usually, yes, if you have a malignancy sitting in your brain, there is a good chance that you might bleed once you're thrombolized, and usually pressure effect from the malignancy itself and then bleed on top of it could be quite devastating and life-threatening. Ischemic stroke is usually contraindication, but in the first 6 months. After that, the stroke or your infarction matures. So unlikely they will bleed after that. Pregnancy, absolute contraindication. You can't give thrombolysis in pregnancy. If there is ongoing bleeding internally, you can't. If there is a chance of a aortic dissection, or there is a big aneurysm with a bit of a leak in the wall, intramural dissection, then it's a contraindication. If there is any significant head injury and you don't know whether there might be a problem with the bleed, then unless you confirm that or rule it out, you can't do it. There is an argument here saying that if the patient had a CT scan, then they would have looked for it anyway. But if there is a contusion or concussion, still usually it's a contraindication. Severe and uncontrolled hypertension is a risk factor. It could become organ threatening, so that's a contraindication as well. So in this scenario, the main one would be intracranial neoplasm. That would be the answer. A 16-year-old girl brought to the emergency department 15 hours after investigating approximately 30 grams of acetaminophen, which is your paracetamol, and 2 grams of dihydrocodeine. So quite a big dose of paracetamol and then there is some dihydrocodeine as well. On examination, she was drowsy, GCS of 15, pulse is 105, blood pressure is 170, oxygen saturation of 96. Which one of the following is the most appropriate treatment for this girl? Now, are you going to give her N-acetylcysteine infusion? Going to do a gastric lavage? You're going to think about naloxone intravenously, or activated charcoal, or just a 10% dextrose infusion?
Now, in acetylcysteine intravenously.
Yes, absolutely right. Well done. Well done. So, yes, because you need to give an antidote, isn't it? And it's a large dose. You want to try to save the liver of this young girl. So that would be the absolutely right answer. She needs to start receiving an intravenous infusion of N-acetylcysteine. If her PT or prethrombin time, liver functions, urine electrolytes and glucose is normal, then you might want to start it early. But if, depending on those results being abnormal, you're going to continue up to 30 hours slowly. So that's a UK protocol. It might be worth going through the toxicology, because that's the most common overdose you're going to get in UK, probably all over the world, basically. So it'd be important to go through the protocol of paracetamol overdose, and also when these patients need to go to a liver unit. That's very important, because if there is a fulminant renal failure secondary to your paracetamol overdose, so timing is very important. So you need to make sure that patient is under the right team to consider a renal transplant urgently if need be. It's too late for activated charcoal. Patients presented too late. Flumazenil is usually benzodiazepine overdose. If there is a respiratory depression, this patient's sats were normal, although she had a bit of a dihydrocodeine. Naloxone is for opiate as well, but again, there was no respiratory depression here, and there was no significant mention of her pupils in this question.